Welcome. Good afternoon, everyone, and a very happy Nurses Day and Nurses Week. Thank you so much for joining us today for this very important discussion on the impact of burnout in the nursing and midwifery profession. My name is Cory McMahone, and I am the Chief Nursing Officer here at Partners in Health. I am joined today by a fantastic panel who will be discussing the real challenges that nurses and midwives are facing globally when it comes to burnout and the impact on our patients. The past couple of years have really highlighted the continued challenges and stress placed on our healthcare systems and workforce, especially our nurses and midwives who are often the first point of contact for our patients. As nurses and midwives, we often operate from a place where we always put our patients first, despite many obstacles and challenges that we face. I'm really excited to have this very important and fruitful discussion today with our wonderful panelists. With that, I'm going to introduce the other panelists who are joining us. First is Marc Julmisse. She is the Executive Director at Zanmi Lasante in Haiti and former Chief Nursing Officer at HUM. We also are joined by Birgit Umaigba, who is a clinical instructor at Centennial College, a mentor, speaker, and critical care nurse in the Greater Toronto area. Judy Khanyola is our chair of Nursing and Midwifery for the Center of Nursing and Midwifery at the University for Global Health Equity in Rwanda. And lastly, Melvin Tamba, who is our clinical mentor coordinator at Partners in Health in Liberia. Welcome, everyone. Thank you so much for joining today. So with that, I'm going to jump right in, I think, to the first question. I think we have a lot of questions and hopefully discussion to get through today. So I'm going to start with the very first question here is, we are all aware that the pandemic really accelerated nurse burnout around the world. Want everyone to reflect on if you could share a little bit about what is burnout, how do you personally define it, and what are other stressors contributing to burnout and exhaustion. So Marc, I'm going to pass it to you first to answer, and then maybe Birgit, if you can jump in as well, that would be great.
Wow, thank you so much. Hi, everybody. Thank you so much for, it's such a pleasure to be here and share a little bit with you. And I think just, it's difficult to talk about burnout. I think, like you said, Cory, this pandemic sort of highlighted something that's even more that has existed, that we've had nurses leaving the profession really due to burnout and compassion fatigue. I think some of the things that when we talk about burnout, we're talking about to the point where either burnout does sometimes start with compassion fatigue, which starts with just this it's sometimes coined as the caregiver fatigue. Like at this point, there's so much coming at you. I think when we think about burnout, we need to think about all that encompasses. One, the staffing that's going with it, that's leading to burnout. One, the patients, the trauma that you're seeing, the primary trauma that either you're going through, and the secondary trauma that that you're witnessing in the lives of your patients, and continuing the amount of deaths that are either preventable or unpreventable deaths. And I think at this point, when we're looking at burnout, you're looking at all these things that are coming in, even personal issues, unresolved trauma that you might have. And I think one of the things when we talk about burnout, we also talk about, I want to touch about it, we talk about resilience. And I think into that extent, when we talk about resilience and burnout, or, we use nurses, or we use several, and I'll take, for instance, in Haiti, many times we hear the word Haitians are so resilient. Oh, they're getting over things. And Haitian nurses, after the earthquake that we have, after the multiple traumas and multiple disasters, after COVID, in the US, after COVID, we're hearing that these population of people were commended and as heroes. You are burnt out, but you also commended as heroes at the same time. But we don't really address some of those issues of burnout. And I think that's where we have to look at both sides, recognize burnout, but recognize that what we're commending as far as heroes and being resilient is maybe to really talk about one of the words that an author had talked about is sort of this pathological resilience. They're surviving. And I think we get to a point where we're seeing nurses are continuing to do the work, but you're on automatic pilot, you're surviving, you're doing what you need to do. But we really need to delve into this pathology of resilience and the pathology of burnout and what we need to do to address that, because it's not, for me, I don't think it's easy. It's simple enough to talk about burnout. We have to talk about how we're surviving and not necessarily thriving in that atmosphere.
Thank you, Marc. I think you raised some really important points there, and we need to continue to have these conversations, and as well as talking about the strategies forward. Birgit, I'm wondering if you might want to comment as well.
Yeah, absolutely. Thank you very much. Hi, everyone. Thanks for joining us. Marc has highlighted very key areas when it comes to burnout. He said the word burnout actually doesn't do justice to what nurses are feeling. Sometimes I feel it's just one word that actually doesn't describe what is actually happening to nurses globally. I think it's high time we started naming the symptoms and all the psychological, mental, emotional stressors that are burning nurses down. We're talking about fatigue, like there's this extreme exhaustion that nurses are experiencing. I worked yesterday and we were all so tired. There was just this fatigue in the air that sometimes you can't even get up. You're documenting and you're just looking at the screen. Like there's this tiredness. And when we talk about burnout, I think we also need to mention how hard it is to get to the washroom, and the basic things that are needed to do your job are not really provided, especially with the pandemic. We've seen nurses were already stressed out pre-pandemic because we're already working short-staffed. We already had a shortage of, for example, in Ontario, we had a shortage of about 22,000 nurses pre-pandemic. This is as per the Canadian Nurses Association. Mm-hmm. And you can only imagine what happened with the pandemic. Nurses falling sick, unfortunately, nurses contracting COVID, and nurses just, taking time off work. So you can only imagine what happened to a lot of nurses with this. About 40% of nurses have reported symptoms of depression, anxiety, not knowing what to expect when you show up at work. It is so hard. So the daily traumas that we see, I met a colleague yesterday and she came to me. She's like, oh, I'm no longer in ICU. I'm like, oh my gosh, you left too? That was like the 5th nurse I'd seen just within the last 2 weeks that left the critical care unit. And I'm like, she said, yes, I could not handle it anymore. There's no time for closure. You lose the patient. There's no time to even think about what just happened, to process it. And the next thing, you're slammed with an admission. Nobody asked, are you okay? Nobody wants to know, okay, do you need like 20 minutes off just to settle and get yourself back? Someone just died, for crying out loud. So we're only human beings. We're so depleted from caring for others that we have nothing left to give other than the basic tasks that we need to complete. So nurses are suffering. Nurses are struggling mentally, physically. This exhaustion when you get home, you're like, I can't even do anything else. I can't put my dishes in the dishwasher. Like, I'm just so tired. I want to lay down and that's it. My legs feel so heavy. The back pain, the soreness, there's a whole lot of symptoms that we're not talking about. And when we use that term burnout just summarizes all these symptoms that nurses are feeling, and it doesn't do justice. So it is very stressful to be a nurse right now.
Thank you, Birgit. I think you raised some really, really critical issues that I'm so glad that we're talking about. Certainly, I think that the stress is obviously both from work, but also the role of nurses in the communities and as caregivers that you're talking about, or when they get sick themselves. And then on top of that, you layer on the level of stress in the work, as you described so well. And it really creates a very challenging situation. So thank you so much for sharing that.
Thank you very much.
I'm going to move on to the next question here, and want to hear from Judy. I'd love to hear from you, and Marc again. Can you speak a little bit about what initially brought you into the nursing profession, and now what keeps you in the nursing profession now? And certainly, as given it has been a particularly rough past few years for nurses. Judy, I'm wondering if you in particular can speak to what is happening at, the University for Global Health Equity around teaching and preparing future nurses for this work. So Judy, maybe you can start by answering, and then we'll have Marc and Birgit again.
Thank you so much, Cory, and happy Nurses Day, everybody. It's really a pleasure to be here this night. It's night for me, or this morning. And really to answer what brought me to the nursing profession, it's in a really roundabout way that I came to become a nurse. It wasn't really my first choice, but in Kenya at that time, the system of education was such that you needed a certain threshold to get into a certain university, and I didn't quite make that cut. And then so I was put into another university, which surprisingly actually had nursing, which wasn't there in the first university that I had chosen. And I actually, they just randomly selected me to do the interview. And when I did the interview and answered those questions, I was really intrigued. And coming out of that room, I said, hey, this isn't quite what I thought it was, because I think, like many of us, I had a stereotypical view of nursing as just, sort of just pushing a trolley, giving patients medicine, and then the dirty aspect of it. So when they asked me scientific questions, which I felt I was like, wow, this is great. I want to do this. And surprisingly, I then started, and I excelled, I must say, around a lot of the things. I started doing cardiac nursing. I found it so exciting to just understand how the heart works, what happens when something goes wrong with the heart. And then I think as I continued into the profession, and what has kept me in the profession has been that, how can I call it, the meeting point between the science of it, like I mentioned. So you need to know the heart, the physiology, the pathophysiology, the anatomy, then there's a lot of chemistry, which I remember failing once and having to do again, and all of that, which is very scientific. But then coming to that juxtaposition where you're really looking at a human being and then being compassionate, being with them, dealing with this other person. And actually, that's why this brings us to the burnout, is because we are faced every moment with another human being who is either suffering, in pain, less than themselves at that point when they come to us, and having to deal with them, which I often say, perhaps doctors don't quite face it as much as we do, because there's a transference that happens the moment you touch somebody, the moment you ask somebody what is wrong with you. And then just from that moment moving forward, it takes a life of its own. So I think what has kept me in the profession has been precisely that I want the science that I learned in my nursing school, the evidence that underpins the work that I do, as well as now the compassion and the caring that comes with the nursing profession. So often it isn't just about a disease or a pathology or a bed or a name, it's about more than just that. And I think that's what has kept me, of course, as I've grown in my career. I've been fortunate to be able to impact things around, maybe a little bit about decisions, about policies. Where I sit right now, I can certainly input a lot into this should not be in and this shouldn't be in. But that came really from that decision long ago that brought me to nursing, that keeps me nursing every single day. At UGHE, where I work and head the Center for Nursing and Midwifery, we're doing a lot to prepare nurses, and I'll speak particularly today, maybe to prepare them for that eventuality that Marc and Birgit are talking about, comes to compassion fatigue, when it comes to burnout, when it comes to the pressure that we face as nurses caring for others. So someone always says, who cares for the carer? One of the things we are doing is around curriculum. I think it's important that as we develop curricula, we remember this and embed resilience within the curriculum. So topics that then are geared towards supporting nurses to face burnout. First of all, to understand it. So if we can't deal with something we don't know, we don't understand. So we talk about it, we put it in there, we say, how do we care for the carer? It's important to care for yourself. When we talk about leadership, we start with first leading self. And one of the things in my sessions, if you've been able to attend by a miracle, one of my lessons, I talk about self. And before I can manage someone else, before I can manage a system, before I can manage an organization, I first have to manage self. And in managing myself, I have to know at what point am I burning out, like Marc is saying? Do I understand? Do I know what are the triggers? And how do I manage myself so I don't get to that point, bearing in mind that we are in an industry that I think burnout is just, what do you call it? It's par for the course. The delivery of our curriculum also, because it's very hard for a nurse like Birgit to work where she is in the Greater Toronto area and then still undergo a training program. So then we expect her to be in class. That adds more to the pressure she's already under, just keeping her head above the water and surviving like we all are. So our programs are very versatile and flexible. They are very, most of them are geared towards working nurses. And so we don't put in a lot of effort. In fact, I sit a lot with staff from PIH to say, we can't do this, it's too much work, let's reduce it. We can still gain the competency, even if they don't need to sit for 5 hours or 10 hours or 30 hours. I comb articles to say, instead of making someone read 20 articles, can I just put one good article that they can read that will still give that information? Thirdly, I will just quickly talk about collaboration and partnership. So with PIH, UGHE, with other universities, we are partnering with the University of Washington, with the University of Michigan. We are partnering with institutions in Africa like AfriHealth and AfriPen, AfroPHC. All of these are supporting to make a robust structure. And a robust structure then supports a nurse from burning out, supports a nurse to do their job and to be there. So in terms of putting money, in terms of putting systems in place, and I'll talk about this later, but that's another way. And then last but not least, very quickly, I'll just talk about the use of technology. So a lot of the things that we are doing, if you can do it on your own, watch a video, recorded videos. We are working with Lecturio, with Scholarettes, with Osmosis Nursing. All of these are ways in which then the education offering that UGHE gives does not contribute to further burning out the nurse, but actually supports them by giving them that very needed information and education. I will stop there. Thank you.
Thanks so much, Judy, for sharing that. I wonder, Birgit, if you could share a little bit with what both what has brought you into the nursing profession like Judy did and what keeps you in the nursing profession, but also share, currently what it has been like to be an emergency room nurse. That would be wonderful.
Thank you so much. I could listen to Judy for the entire day. Judy, you nailed it. Like just going from the scientific to policy to leadership, collaboration, and from curriculum, she covered it all. Amazing. Thank you for all your work. So yes, I actually never thought I was going to be a nurse. I never thought of it. I remember when my mom mentioned it back many years ago, I was like, no blood. That's it. And somehow, as going back to school as a mature student, I was like, how can I get into the workforce as soon as possible and start making an income to be able to support my child? Because at that time, I was a new mom, and it was nursing, and that was the only reason I decided to be a nurse. My background was, accounting, and I always wanted to be a doctor, but that ship sailed. But yeah, so I decided to do nursing, and oh my goodness, did I love it. From the very first semester, I fell in love with nursing. Just like Judy said, the science of it, the humanistic aspect of it, the caring part of it, all of it, I connected so much. I found myself. I actually said, you know what? I think everybody has to go through a nursing program just to understand what it feels like. Just the program. You don't have to work as a nurse. I remember staying that through nursing school. And I loved it. I remember my professors asking me if I was a nurse before or things like that. That's how much connection I made with my program, with clinical placements. I loved every aspect of it. I'm like, this is me. Like, I didn't see myself working behind a desk at all as an accountant. I'm like, why did I ever think I was going to be an accountant? But so, yeah, that's how I, started practicing as a nurse. Of course, it wasn't easy in the beginning. It was very difficult as a new grad with, again, not enough support. I think nursing has always been like that. Not enough support, but, I managed to survive the critical piece aspect of it, which is usually the first year of being a nurse. I hear research shows that a lot of nurses will quit in the first year. So I survived that phase, and I'm like, yeah, I'm a nurse. I survived. So yeah, why do I stay? Why am I still in the profession? Genuinely, I love nursing because I have this connection with my patients. Every time I walk into the hospital, irrespective of the chaos and the short staffing and things not working well, I go with the mindset to make an impact in someone's life. If it's just the little things of making them feel so good, washing their hair, making them look so clean, presentable, speaking with family, being able to be that support. It makes me feel like I am contributing to humanity. And it just comes, for me, it's so fulfilling. It's natural. I feel like I'm a people person, and I've had opportunities to leave the bedside completely, but it's so difficult because I want to be able to connect with my patients and give my part as a nurse. And the other aspect of it, I ventured into teaching, and I've been able to mentor new nurses to be able to guide them through their career path. I actually do work with some of my former students now as colleagues, so it is very rewarding. So all of this actually keep me going and help me put things in perspective when I think of quitting, especially with all the stressors we've been talking about. For me, nursing is very rewarding personally. Just going into that room to provide culturally sensitive care and being able to inform my colleagues of what it feels like to be someone who's Black and who has sickle cell anemia, and being able to actually guide them with that knowledge of how important it is for us to understand, this cultural aspect of care for maybe an indigenous family that need privacy for smudging or things like that. So all those things, I have this connection with my patients and their families, and it just gives me true meaning to what life is. That really does. Those are the things that keep me going. And that's actually one of the reasons that I find it very important to advocate for my patients and nurses as well. And all of that, when it became really difficult for me to provide the level of care I wanted to provide, that's when I took to advocacy. I'm like, okay, it's not possible. There's so much I want to do. I'm not able to because I'm overworked. I'm overwhelmed. I cannot forget the one shift when I told the patient I was going to be right back. He was going to talk to me because he was recently diagnosed of cancer. I could not go back to the room. I had 9 patients that night, and I took that with me. I felt terribleness, and I still remember, and every time I think about it, I have chills because I feel like I failed that patient. The system did not allow me to provide person-centered care, and that is not the type of nursing I want to practice. I want to be able to give my best to be truly present with patients, and that propels me into advocacy, and hopefully one day be able to inform policy. And I've been able to write tweets that were seen by members of provincial parliaments and read in parliaments, just to share these stories in order to better the working conditions of nurses, so we can provide patient-centered care that organizations want to provide. So yes, I love the science, the humanistic aspect, and of course I love the policy aspect. Nursing is political.
Thank you.
Yeah.
Thank you so much for sharing. And I think you really highlight the need for the structures and systems that we need to have in place so that nurses can show up with that heart-centered, humanistic approach to care, which is just as important as the science side of things. And so to be able to have that, it requires those structures and systems. And I think that's really important that we talk about. So thank you so much for that.
Thank you very much.
Melvin, I'm wondering, maybe Melvin and Marc, you could share a little bit about how you think about compassion fatigue and what you guys are doing to deal with compassion fatigue. Melvin, I know he leads a lot of our work as part of our nursing in Liberia, and this really came to the surface very early in the COVID pandemic. So Melvin, would love to hear more from you.
Thank you so much, Cory. I'm really excited to be a part of this forum, and to all of our viewers out there. this is today is according our birthday. This is International Nurses Day, and we are all excited the fact that we are nurses and we know what it means to be a nurse. And this is, for me, I look at it like a natural calling, because you must know, if you don't have that passion, if you don't have that love, it makes it difficult for you to be able to provide the care for that patient. So coming from the past of Ebola, more especially for Liberia, you know, and talking about compassionate fatigue, and working in an emergency room, it's really a challenge, because working in an emergency environment and considering burnout, you know, those are critical units in a hospital setting that makes you as a nurse be more like involved with patient care, but especially when you find out that there is this patient that is critical, you know. So it's a difficult situation, but again, you need to ensure that you understand how that patient feels. You know, you have to be putting yourself in the shoe of that patient, be that kind of a person that will look at that patient on a holistic aspect, where you feel that this patient needs your care. And as a nurse, a leader, you need to show that you study more about how your staff are involved when it comes to compassion fatigue, because we know that a lot of nurses work overtime and they don't have the time to actually have some time to rest. And because of the demand of the work, you find out that some of them work, you know, almost double shift. So within this kind of a situation, you find out that you have to be very sensitive and ensure that you help your staff along the way to be able to help them to cope with the challenges of burnout, because there are a lot. Sorry, my lights just went up. There are a lot of challenges when it comes to compassionate fatigue, because there's a nurse. Say for instance, we have a situation where the COVID-19, because in Liberia there was a strain that was strange to us, although we came from an Ebola background, but we didn't really have broad knowledge on how to manage COVID cases. So when we had the first episode, the first case that was reported, it was kind of alarming for us, because we never had a basic knowledge and skill how to manage COVID. So we found ourselves in a difficult situation, but notwithstanding, we're able to involve people, because this is we found ourselves working with diverse people from different diverse backgrounds, and we decided to involve people from the local authority, our community health team, our mental health team, to provide psychosocial support, you know, to ensure that staff are protected and getting involved, delegating tasks, because if you don't do so, you will definitely face with burnout. So I just want to say thanks again. Maybe my colleague will come in with some additional information when it comes to compassionate fatigue. Thank you.
Thank you, Melvin. Marc, would love to hear from you too of how you think about how to manage compassion fatigue and what you're seeing.
Yeah, thank you so much. Can I answer one question? It just really, I laughed when you talked about your mom. One of the questions said, how did we come into nursing? My mom, initially, I didn't have a choice. She said, you're going into nursing. That was it. There was no discussion. And I would tell you just really quick, I went into nursing. I was that one that left after about a year. My first year, actually, I was like, nope, this is not for me. I'm gone. And I went on a short-term mission back then, on a mission as the site nurse for the short-term mission, and was in the community and actually had a experience and ended up working with some clinicians there, which really showed me what it was about rather than just going in there. And that with the people that I've encountered, specifically one throughout the life, but one professor, I could say, because of her love of, we mentioned a couple of times, science and compassion, and the way she married the two. And another part was really looking at really the love of details and observation, which we call evaluation. When we're digging deep, and how do you bring those two together? So when we're looking, it's almost like you are an investigator and you're trying to figure out how to get this or provide the care that you can for your patient. And coming back to that, this, and I'll say her name, Eleanor Pusey Reed, and really this professor has changed it and shift. And that's what I have in the back of my head in every case I've come into, every patient I gave care to, is there's more. She used to say something like, if you see a hoof of horses, look for the zebra. If you see the norms, the patient is here because of the abnorm. Know your norms and figure out what's that abnorm and how do you bring that puzzle together. So I always saw it as this investigator. But I'm going to get to the point that you talk about compassion fatigue. This is the love that I have in nursing. And one of the things is just to talk about compassion, which sometimes is described as the sympathetic consciousness of others' distress, together with the desire to alleviate it, right? You have this sympathy, you see with this compassion, and that's sort of like embedded in the nursing culture, right? That you have both sympathy, but we have the skills, we have the knowledge, but then sometimes if we want to really talk about compassion fatigue, is the systemic issues, right? That you go against. It's not just, and then that ties into burnout, because the systemic issues that you're talking about, we're here to provide and alleviate some of the stress and the suffering that our patients are going to. But one, you either don't have the correct materials that you need. You have lack of staffing, chronic lack of staffing, critical lack of staffing. You have lack of or you have a high acuity or high acuity of patients, or you also have, and one thing that we don't really put it, you have lack of mental health support. These systemic issues where you're constantly facing some of these traumas, or constantly being in the face of patients that are encountering traumas and have to either be, and let's address it, also be on the brunt end of being physically attacked. And that's something that we have to discuss, or verbally attacked, or verbally you are, by either the patient or family members. These are all things that we're looking at. And I know a couple of years ago, I believe it's Massachusetts, that did enact some laws to protect nurses and clinicians. But let's talk, when we're talking about compassion fatigue, if I'm giving my all and I'm here to try to figure out how to alleviate that distress, or alleviate some of that, the pain and suffering, and really on a clinical end, for both the emotional and the clinical end, provide the care that we need. But if you are chronically in a lack of supply and chronically in a lack of staff, if we don't address the systemic end of it, that leads to also compassion fatigue, because now you're hitting constantly a barrier. And how are you providing care for your patients? On top of that, there's the other social aspects. There's there's other aspects that we have to add into that. And I misquoted it earlier, but compassion fatigue is also called the cost of caring. It said it's the emotional and physical fatigue that progressively develops in professionals. And I think sometimes we don't even realize that you've entered into compassion fatigue. I'm just tired. I don't want to do this. They don't care, or patients, like, it's like you're constantly fighting against the grain and you're moving forward. But I don't think you realize, I think it's the exposure, compassion fatigue, compassion burnout can lead because of exposure to either secondary trauma that you're seeing in your patients, primary trauma that you're having, the stress, the systemic issues that you're dealing with overall to provide care for your patients, a lack of understanding from sometimes administration. And I have to tell you right now, being in a different position, I did frontline nursing. I was, and I still try to do it also, although not as often, community health nursing and clinical. And one of the things, now I'm on the administrative side, and I also have to realize that I have a responsibility to my team, because in their understanding, it's not just filling the quota of how many nurses do I need per shift. Do I have you know, how many patients to take care of, or it's not just about the scheduling. It's actually, are they okay? And I think one of you guys asked for somebody to ask, are you okay? But sometimes when we ask, are you okay? Am I, or on the administration side, have we put things in place systemically to make sure they are okay? We are okay. And as we're asked, do we, and this is on moving forward, and these are things that I'm holding myself and our team responsible on the leadership side is, are we asking those questions? Are you okay? And when I'm asking it, am I listening? And if when I'm listening, am I putting structures and systems in place to make sure that you know that you have a community with you? And these are things that hit me. I think, was it last week that there was a nurse that killed himself on shift? And I don't want, it's not to blame anybody, but the question is, we fundamentally, I don't want to just put it and leave it at burnout, but we need to address the systems that lead to compassion fatigue, that lead to burnout, that lead to people walking out, and also address it so that nurses are recognizing, when are you stepping into burnout and when do you ask for help? Because in that, if I don't recognize that I'm burnout yet, I just feel like, oh, I'm just over and done with this. But I think those are some key aspects that we need to really answer. There's just one more thing I really want to talk about is, and the other part of it, we're talking about sometimes frontline workers or bedside or primary care, but sometimes we also need to ask the same of the nursing leadership. Are you okay? Because at this time you have two aspects. You have organizational, and you also have the disciplinary, right, aspect of it. And then sometimes organizational, we're implementing decisions, whether you agree or not, or your hands are tied where you see a solution, but you don't have the systems in place in order to provide the support that you need to your staff, to your team. And so on that end, you will see leaders, nursing leaders, leave that part of it and decide not to stay in leadership. But we need people that understand it, that are constantly, when you talked about Birgit and Judy about that policy and advocacy, we talk a lot about policy and advocacy for our staff. For our patients. And I think there's another part that this is me going in and saying, like, Marc, change your paradigm and start thinking about that. I just don't advocate. My job is not only to advocate for my patients and the patients that are coming in. I need to advocate for my staff and say, like, are we there providing them the systems, the background, the support that they need to provide the care for the patients they are. So as I'm talking about this, I'm holding us responsible for saying, what do we need to do in order to say, when I ask you, are you okay, that we're ready here to be that safety net.
Thanks, Marc. So many amazing things that you said there. And I think also kind of critically important. And I could spend the rest of the time just reflecting on that too. I wonder, Birgit, if you want to also comment a little bit about what it has been like to be kind of an emergency and critical care nurse, but also really around some of what Marc was just talking about, speaking to what are the resources that should be available, and what are some structures and systems that can really be part of the solution in all of this, because that, it seems like, such a critical component that is very clearly missing a lot of the time.
Thank you very much. Marc, you highlighted so many key areas, and I'm glad this has been recorded because I'm going to listen again. The question, are you okay? Do we have the systems in place to respond? What if you ask a nurse, are you okay? And the nurse isn't okay. And there ought to be a follow-up, a solution to be able to make sure the nurse is okay. But I think a lot of times we ask, are you okay? But we're not ready for the answer. And this is why people say, yes, I'm fine. But underneath that, a lot of nurses are not fine. And we're used to putting ourselves last. We're used to not putting ourselves first. And that's why we could go on for like 6 hours without a bathroom break, 6 hours without hydration break. This happens all the time. I'm yet to see a job where you give yourself so much. You give others so much, and yet you give so little to yourself while you're working. I've worked shifts where I wasn't okay. I remember working during the pandemic. I had my full PPE, my N95 mask, face shield, isolation gown, gloves. I was heating so bad. My patient was dying. The family was in the room, about 5 of them. They had an exception to be there. And I was there while they were saying their final goodbyes. I was crying. My mask was soaked because it was so heartbreaking. I had a relationship with the patient before the patient passed. And here I was hearing all these nice things about the patient who was dying, and the patient died. And underneath that mask, I had to be strong. Underneath that mask, I had to pat the family members on the back and say, you know, I'm here to listen. I'm here to support you. And things like that. Offering support, even though I needed support. Yes, I was doing my job, but I'm also human. And I walked out of that room, I cried because it was really heartbreaking. And the fact that after that, I had to, you know, clean the patient up, wrap the body in preparation for the morgue, assist the porter, the things nurses do beyond belief, assist the porter to transfer the body into the morgue carts. And sometimes there's no porter. You end up assisting to also transport the patient. So, and after all of that, you have to get ready for the next admission. Was I okay? I wasn't okay. Was there support? Absolutely none. Occasionally, you have that one colleague who sees through, I'm fine, and says, oh, you're not fine. Maybe is there something I can help you with? Occasionally, you have the one or two. I try to be that person for my colleagues, but not everybody is that sensitive to other people's feelings. They just expect you to do the work. And the nature of my job, I fall through the cracks when it comes to support. A lot of agency nurses, we don't have that team support because we travel from one hospital to the other. We're expected to survive, deliver, leave. There is no follow-up. There's nothing. We need systems to be in place. We actually do need a deployment of mental health resources for nurses during their shift, not waiting for people to ask for help. Like, a lot of people don't even know how to ask for help. I don't even know how to navigate the mental health resources in any of the facilities I work. I have never had to. And you can't even imagine how many people don't know how to access these resources. They're not accessible. And even when they're not available to a lot of people. You have to be full-time. And mind you, a lot of nurses work in precarious positions like myself, part-timers, casual workers. They don't qualify for these resources, yet we give ourselves so much. I know a lot of casual staff that work full-time hours, but yet can't qualify because they're not under the umbrella full-time. It's so sad how disrespected nurses are. And there's a lot that needs to be done. And I could go on and on. Currently in Ontario, we have a wage suppression legislation that's been in place since we had the Conservative government. And despite an increase in workloads, I mean an increase in workload, I have worked shifts where we had 10 nurses for 22 patients. There was supposed to be a minimum of 18 nurses for the shift. So we had to shoulder the burden of working for 2. Despite that, we have a wage suppression legislation. Our salaries are frozen, they're capped. We cannot bargain despite the increase in workload. So people are leaving as a result. When it comes to emergency room nursing, it is so challenging. You're the first, people come in, irrespective of what they have, you're there. You're the first person they see. You're constantly exposed to all kinds of, diseases. Before people are placed on isolation, the emergency room nurse sees them. And a lot of times we have people in the hallway. I worked in the emergency room one day, and I fell out of a patient's pants in the hallway. It could have been anything. And there is no support, there's no structure. The organization, things are not working, and it makes working very difficult. I always talk about the little things, the basic things, just having supplies where they're supposed to be, having things working. Sometimes you spend 5 hours of your shift looking for supplies. So there are a lot of things working against us to be able to complete our jobs. I still remember when we had a lot of people pass and dying from COVID, and we had a long wait. The morgue was full. We had a patient who was dead for hours. We couldn't transfer the patient to the morgue because there was no room. And the patient had to be there in the emergency room. So nurses don't get support. Whether or not you go for a break, you're just expected to keep seeing patients and keep seeing. Once in a while, someone tries to relieve you, but who's going to do that? Another exhausted nurse. And I feel that everybody's so depleted that there's nothing left to give each other. There is no compassion for one another. So in addition to administration, not getting support from administration, we really get support from each other because we're done. We're tired. We're exhausted. We just want to complete our task and go home and call it a day. Yes, we do need systems in place to work, systems that are actually functional. We have a shortage too in all other departments like physiotherapists. Sometimes you want to get your patient up. You need a physiotherapist and there's nobody there and you're expected to do that. And then you start feeling this burden, this compassion fatigue of not being able to complete your duties because you don't have the resources to. And the nurses have to document what you've done, or like you have this burden constantly. Am I doing my job correctly? Am I doing everything right? Am I crossing all my T's? Am I dotting my I's? Despite the pressure, despite the increased workload. And it is a lot. It is definitely a lot. So we need systems to be fully functioning in order for us to complete our jobs, properly.
Thank you so much. There's so much in this conversation. I too am going to go back and watch this, and I'm also reflecting on my time at the bedside too, and it resonates so much, everything that everybody is saying. So deeply appreciate that. I think we're going to have to wrap up soon. And before we do that, I wanted to take a minute for a final question and final reflections from each of the panelists. So this if there's anything that you each want to respond to from this rich discussion today, and final thoughts that you may have, as well as if you have any comments around how you personally approach and handle burnout during these times. So I'm going to start there. I'll start with Melvin, and then maybe Judy, and then we'll get around to Marc and Birgit before we wrap up. Go ahead, Melvin.
Thank you, Cory. Yes, personally, like other people have been saying, we have this challenge of managing burnout all over, well, especially during this pandemic period. But personally, I have been involved with multidisciplinary team working across our various sites. And the COVID pandemic actually exposed us, because there you will realize that this was a strain, a virus, and we didn't really have the kind of preparation to be able to manage, COVID. But then when it comes to how personally I approach it, is that I was able to involve a lot of, teamwork, and get involved with a group of people that we feel that can be of help to ensure that we be able to manage the system, have the system to continue to work effectively. And this is where now we have this mental health team that also was able to be very, very involved in terms of providing psychosocial support. So what I will also say is that during the pandemic, we have this situation where we as nurses needed to show that we can restore confidence among the public, because again, for our setting, more especially in the limited resource setting like Liberia, we were we didn't get to know where to turn because, again, resources are so limited, and the facility that we run, it is the only public health facility that provides free health services. So it was a real challenge. People have confidence in the system, but then when this pandemic came about, it was a challenge. We found out that some people was like shying away from coming, more especially for routine care services. But personally, I was able to involve a lot of people into this fight when it comes to this pandemic issue, because I know for the word that I alone cannot do the work. You need people to come around. You need people to get involved because, again,
I think we're losing Melvin with some internet and bandwidth issues in Liberia. We will certainly come back to Melvin. Oh, Melvin, I think you're back. Are you there?
Yes, I'm here. So, yes. So, like I was saying, we got people involved with dedicate, a lot of responsibility to others that will feel that can be able to be of help to the process. And we're able to do a lot because, again, we have an incredible team that we could look up to in terms of giving some support, our community health team, our mental health team, and even providing services where we feel that when our staff are burnt out, we're able to provide some counseling, giving them time up to do some reflection. And because, again, if you are not mindful, somebody will come down with this issue of compassion and fatigue. And this is very dangerous. Mark was, emphasized it a lot, where sometimes you find out that this patient or this staff or the nurse is overwhelmed. This nurse has worked over time, but you still feel that there's a need for you to be able to provide that care for that patient that is in dire need. And at times we tend to even forget about our own social need. You don't have the time to even have lunch for yourself. Sometimes you don't have the time to even have a good meal. You see the kind of sacrifice that we nurses are involved with. It's a lot. So there's something that needs to be done to put system in place, because if we don't do so, these things going to drive away nurses from this profession. And one of the ways that when I was going through this burnout issue is that we need to now see how we can specialize. Because again, if you look at the entire nursing field, and for me, I did general nursing, but now there are a lot of areas that we can be specialized. If you specialize, you'll be able to be, the workload will somehow reduce, and then you find yourself even playing some other leadership role, like what I'm doing right now. I'm both involved with clinical, and I'm also involved with leadership. So there are a lot of things now that I find myself being multitasked, and I see that impact is being felt among my colleagues, and even when it comes to patient care. So I just want to say this is a great opportunity, and we are learning a lot from this forum, and good that it's being recorded. We're going to listen to it to help us, but there's a need to have a system put in place to ensure that our nurses are safe, because burnout is something that is very serious. It's affecting our nurses around the world. And as you know, nurses constitute more than 50% of the workforce globally. And whenever we have a pandemic, we now feel how nurses are being involved, because without nurses, we will not be able to get to where we are in terms of conquering this pandemic. Thank you so much.
Thank you, Melvin. Judy, I'm going to pass it to you for final thoughts and reflections. You might have to keep it to a minute or less, because we're really coming up against time. But so many wonderful thoughts and comments. So Judy, go right ahead.
Thank you, Cory, and thank you, everybody. I think for me, it's obvious that the systems and the structural supports need to be in place to support or as a solution to this issue of burnout and fatigue with nurses. So one of the things I'm glad is that COVID came, because it threw into sharp relief the importance of nurses and midwives. Everybody now, when I speak and I say I'm a nurse, they turn, they ask a question that wasn't there before, because many times they used to take us for granted. And I think the fact that people are living in droves is forcing the hands of policymakers and decision makers to sit down and face this issue head on. So for me, I think despite the challenge, and Birgit and Melvin have explained what it is to work as a nurse and why we're burning out, I think still there is so much room for optimism and hope, because now in the tables as we sit, someone is going to sign the budget. The cap freeze is going to get off. The hiring freeze is going to be removed, because in Kenya, my own country, they're exporting nurses to the UK. Our president signed something that's taking nurses to the UK. And we said, hey, wait a minute. What about ourselves here? What happens to when we all run for money, Great British pounds in the UK? What happens to us who are earning good old Kenya shillings and looking after the Kenyans? So now that conversation is happening, because policymakers don't look at it the way we do. The fact that all of us are talking about it is good, because now the voice of nurses is being heard. Birgit, I'd love for you to stand in front of a minister of health and explain exactly that. I am working and there's a dead body right there. Could I bring this one to you, Madam Minister or Sir Minister, and have him answer that question? I can tell you right quick, he's going to sign where you tell him to sign. So I guess for me, what I would like to leave with that sense of optimism and hope that it isn't all bad, it isn't all doom and gloom, and that yes, we are facing burnout, and yes, we are facing fatigue. But I think this in and of itself, good will come out like a phoenix rising out of the ashes. Very quickly, I'd just like to say that we need workplace supports, we need systemic supports, we need educational support. How do we view nurses? I think the fact that COVID has come, that these discussions are happening, is changing the way people view nurses, because they're now looking at them and saying, oh, you've been taken for granted for so long, they're doormats, but now we're like, no, and people are now viewing nurses differently. Who should join nursing? That's something that really, as for me, when I sit from the educational side, it isn't everybody. The fact that we are burning out sometimes is because we might have the wrong person. And that trickle effect is something I don't want to see. So I'm pushing back and saying not everybody should be a nurse. The right people should be nurses, because I think that resilience, that ability to absorb comes when you're the right person. But then having said that, last but not least, is that those of us who are so passionate, Marc, Julmisse, Birgit, Melvin, Cory, all of us here who are so passionate about nurses, actually the first to burn out. We love our work so much that we can't disconnect. And it's important to avoid burnout that you do disconnect. So we have to find it in ourselves to not burn out because we love the profession so much. How do we disconnect? How do we intentionally take time off? There is no pressure to feel better. I always say there is no pressure. How are you? I'm not fine. Okay. You don't have to feel better today, tomorrow, next week. There's no prescription of Birgit, you've gone through that. There's no time that say by July 1st, you should now be okay. Okay, so again, let's take that pressure off ourselves. And I think that will help us even work better. When I know I'm feeling sad and I'm mopey and I'm not happy, I've come to work and I'm not happy, leave me alone for some time. But that ability to do that is what then we need to put in place. Building our own emotional skills, just like a marathoner trains to run, that's physical fitness. We need emotional. How do we do that? And again, a lot of these things are what we've discussed today. Wish we had more time, Cory, but over to you, and thank you so much.
Me too, Judy, me too. I think we have to wrap up there. And I think, Judy, you gave some final wonderful words there, and just extending my deepest gratitude to everybody for being part of this panel today and this rich discussion. And hopefully this is just the start, and we can continue to bring awareness and visibility, as well as put in place those structures and those systems and caring for the carer that you guys spoke so eloquently about. And thank you. Oh, yes, go ahead, Birgit.
Sorry, thank you so much. I just wanted to say that we actually do need all governments to strategize and come up with innovative retention strategies for nurses. We've heard that nurses are leaving in droves. So we need to be able to retain nurses, and that has to do with retention bonuses, increase in pay, loan forgiveness program. I don't see why we can't have that. And we actually do need nurses at every decision-making table. So valuable. We need this to be at the policy level, and we need it to happen, not just words. So yeah, thank you so much.
Thank you. Couldn't agree more. Thank you, everyone.
Thank you.
Thank you so much.
It was lovely. It was lovely.
Thank you.
Thank you.
Thank you so much.
Thank you.